Thank you very much. LeadingAge.
Thank you. Thanks so much for the invitation to testify. My name is Diane Darbyshire. I'm the Vice President of Advocacy and Public Policy at LeadingAge New York. And for those of you that aren't familiar, LeadingAge New York represents approximately 400 non-for-profit and public providers of services for the aging throughout the continuum. That includes home care, provider-sponsored managed long-term care, adult care facilities and assisted living, nursing homes, senior housing, really essentially the whole continuum. And it is with that unique perspective that we share this information with you today, because we really look at aging services holistically and look at how it touches different parts of healthcare. And I know that you've heard from people today, there is a workforce crisis throughout the state and throughout different sectors, but I want to just quickly highlight a few reasons why we need to be particularly focused on long-term care. First of all, there is currently access issues that are happening right now, and that in and of itself is devastating for anybody who needs services and is waiting, for anybody who has loved ones that is trying to kind of make things work while they're waiting for necessary services. And this is because of the workforce shortage that we're experiencing right now. Access issues have a ripple effect throughout the whole healthcare system. So access issues to long-term care in and of itself are serious, but they cause backups in hospitals, as Stephen said. When somebody can't leave the hospital because they can't access home care or they can't access a nursing home bed, that means that somebody who does need hospital services is not able to access that bed. And it also results in financial losses for that hospital. Access issues can also result in the overutilization of 911 and emergency response services and the emergency room, which also creates backups, which prevent others from accessing needed care. And all of this also results in increased costs. So I just want to highlight that access issues in long-term care are really access issues for all of healthcare. And thirdly, the demographics unfortunately show us that this is only going to get worse. We haven't even seen the worst of this. We know that the older population is growing in New York, where the younger population of likely caregivers is not. And meanwhile, there are more and more people living alone. And this is really an issue for everybody to be concerned about, because according to the Administration on Community Living, 70% of those of us that reach age 65 will need long-term care. So this is really something that we should all care about. And fourth, Medicaid is the primary payer of long-term care in New York. And this is particularly true for nursing homes and home care. So like other sectors, there's no ability to really raise prices to be able to make up for inadequate reimbursement. New York State bears the primary responsibility for adequate funding of these services. So we must stabilize the long-term care workforce. We really can't afford not to. And waiting longer, this is only going to get worse. Our written testimony provides a few suggestions that will help ameliorate some of the pressures on long-term care and hopefully promote working in this field. But it is critical to understand that without significant financial investment in these services, those other initiatives are not going to solve the problem. We fundamentally need to invest in services that are publicly funded for long-term care, and that is really what is absolutely necessary immediately. And what we're talking about is reimbursement that meets the cost of care. That's foundational to ensure that we have the ability to recruit and retain quality staff and provide quality care. And we certainly understand that ask has a big price tag, and we appreciate that providers, nursing home, assisted living program providers, adult health care providers received a sizable Medicaid increase last year, and we want to thank those of you. We know you fought for even more, many of you in this room. And we're not ignoring that. Unfortunately, the fact of the matter is that that money quickly was spent, due to rapid increases in inflation and wage increases. An investment in long-term care pays dividends in that it alleviates burdens on other parts of our healthcare system and reduce costs for hospitals. But we do want to just highlight that we agree there are some things that can be done with the nursing home staffing mandate to better reflect the needs of residents of nursing homes. We also think medication aids would be something that is a no-cost initiative. We can borrow from what other states are doing and what we're doing here in New York. Even my own brother receives services from OPWDD services, and if it's safe for him, it should be safe for our grandparents. So I believe my time is up. I apologize, but I do think that that is one low-cost thing or no-cost thing that we could do that would have a more immediate impact.
Thank you very much. Josh, do you have questions?
Yeah. I have one or two. First one is for Diane. You mentioned in your remarks about med tax medication aids and them being in practice in other states. How many other states are safely utilizing medication aids to pass simple medications?
It's our understanding that 33 nursing homes are, although I know Stephen said 34, so it's 33 or 34, and I know that other states are using them in other settings as well, but 33 in nursing homes is ours.
So to give Jonathan a break after his question from Chairwoman Paulin, for both of the long-term care advocacy groups, when we're talking about allocation of staff resources, one of the things that I've heard from facilities across the state is an outdated requirement that may still be in place to do the HERD survey. What is the staffing requirement that nursing homes are being mandated to complete the survey when they could have care providers on units actually providing care?
So the HERD survey just, I don't know, probably about 3 weeks or so ago, it got reduced to 17 or so questions. It depends on the provider type. Still a daily requirement, Monday through Friday. For nursing homes, it's largely duplicative of what they're reporting on the federal level with their NHSN reporting. And adult care facilities and nursing homes are required to report to the local county when there is a positive COVID case too. So there's a lot of duplication. It requires a lot of staff time. It's a daily requirement. It would be really tremendous if we could make use of the existing data and do away with that survey.
And so, am I safe to assume that if that survey was done away, that they would provide nursing staff, especially senior nursing staff, more capacity to assist on units with maybe more complex residents?
Absolutely, and support staff. I think what's really important too, we're talking about workforce. We need to build up the staff that's staying there and provide them support. And it's terrible to take any resource away from that.
Is there a concern, and I know you guys both mentioned the impact that the safe staffing mandate has had on both for-profit and not-for-profit facilities. Combining that mandate with the Medicaid funding gap, is there a real concern that if the status quo remains, that we can get to a situation in the very near future where nursing homes, especially in more rural communities, are being forced to close their doors and put not just the residents out on the street and into facilities that may be not in their community, but also eliminate jobs for healthcare workers?
Absolutely, that's occurring now, quite frankly. As I mentioned, roughly 75% of the nursing homes in the state of New York can't meet the 3.5 mandate. They're closing beds, they're closing units. As Diane indicated, there's backups in hospitals as a consequence of nursing homes not being able to take those patients who aren't ready to return to the community into the nursing home. So it's a problem now. Assemblyman Hevesy has a bill that he's introduced that reflects the true direct patient-facing care that's provided in nursing homes. That bill amends the 3.5 law. It includes occupational therapists, physical therapists, recreational therapists. I mean, when you think, for example, a physical therapist working directly hands-on with the resident, why isn't that counted towards the direct care that's provided to the nursing home resident?
And I'll just add, I want to say 5,600 nursing home beds offline that were online in 2019, offline because of staffing. So, this is creating access issues, and it's a serious issue, and we are seeing nursing homes close.
And just to add to the staffing, one of the things I think Mark mentioned, you have a $2,000 per day penalty. So if you have almost 500 nursing homes who can't meet this, we're all recognizing that we're facing a tremendous Medicaid shortfall. They don't have these funds. 75% of nursing home residents are Medicaid residents. So the state of New York, and this was the prior administration, is looking to take money from nursing homes and put it into the general fund while we're in a workforce crisis. We've sent the governor a letter requesting that if these fines are levied, that money go right back into nursing home staffing, recruitment. Don't just take that money and put it in the general fund.
So with 10 seconds left, is there a concern that you guys have that with CMS coming out with their own safe staffing mandate, with it tremendously different than New York State's, that can provide tremendous uncertainty moving forward if that actually goes into effect?
Absolutely.
Absolutely.
It's unachievable, unfortunately.
Thank you, Pat.
Thank you. Just want to piggyback off a couple of those, and I have to say I live between Albany Med and St. Peter's, two of the largest hospitals in the capital region, and we have, unfortunately, we keep hitting the top of the longest ER wait times, and it's often because the beds are not they're open, but they're not available for use at our many of our nursing homes. So I very much appreciate your comments. The certified medication aides. If you could just tell us a little bit more, what kind of training in the 33 other states, what kind of training do it looks like it's a career ladder, as we've heard, for CNAs to progress up. What additional training does that take? And have those 33 other states run into any type of problems in terms of errors, fraud, abuse, anything of that nature? Do we have any data on that?
We can certainly get back to you with data, but what I would say is it's our understanding that in many cases the outcomes have been better, and I think part of the reason is nurses are in such demand and constantly pulled away to attend to critical tasks. So it's my understanding that the data bears out that this is a really successful approach and one that we've seen success with in the OPWD sections.
Yes, but that's the irony. It's already allowed in New York. It's just prohibited from nursing homes. So, and the legislation that's out, that's actually sponsored by Assembly Member Sarah Clark, is very strict. All the medications are prepackaged. They're under direct supervision of a registered nurse. It's a very focused, specific career ladder for CNAs. And what it does, it allows RNs to practice at the top of their scope, as opposed to an RN practicing really at the lower end of their scope, pushing the med card, giving out prepackaged medications. There's certain items in the bill that can't be done, have to be done by an RN, but it's working in the 34th state was Pennsylvania, just passed it. The governor is expected to sign it. And what I will do is I'll provide the committee, I have a whole spreadsheet from our national association that goes through all those states, gives you the requirements, everything. That'll make life easier.